I tell them all the time, I'm here for whatever you need. It's not an inconvenience to call a rapid. It's not an inconvenience to reach out for help. Sometimes we don't know things either. I think that's the biggest thing is sometimes, we have to ask questions, try to just give everybody grace.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today I have joining me Aidan from South Carolina. Welcome, Aidan.
Thank you, Sarah. It's a pleasure. I've been listening for a long time, and I'm glad to be able to join you on the podcast today.
Absolutely. So Aidan is a fellow ER nurse turned rapid response nurse. And today we're going to talk about just that. What are the differences between ER nursing and rapid response nursing? I get this question all the time. And also, we're just going to kind of talk through a case because I think that does a good job of highlighting how the roles are a little bit different, how the approach is a little bit different, how the skill set's a little bit different. So let's dive in. Ada, before we go through this case, can you just share with us a little bit about your nursing journey and kind of what motivated you to transition from the exciting world of ER nursing to what is rapid response nursing?
I followed everybody's new grad advice when I originally graduated and went out and worked on the floor did about a year on the floor. And then I did like med surge, orthopedics, surgical, and then transitioned to the ER after that. Did about 3 years just in the ER. Originally just did adults only and then transitioned to a bigger hospital system, which we did, from the cradle to the grave, did everything. Freestanding ERs, big tertiary centers, everything like that. But then an opportunity for rapid response came up and interviewed for that. I had previous experience working with them in the past. And I appreciated the role, just acting as a resource for nurses and kind of just different skill set that you develop. I could really imagine myself in that role and then jumped at the opportunity when I saw it.
Yeah. So what was it about the role that was enticing to you?
I think first off, just being a resource for the other nurses. I always liked precepting. I did a lot of precepting in the ER, a lot of discharge experience and whatnot. And I like being able to kind of just be that person, like, hey, I need an IV, I need an NG tube, or what do you think about this patient? I like to kind of just be that person that's going to be non-judgmental and patient for people and run through patients, run through anything that they need and just be there to listen or to help them.
I love it. You highlighted a really important point that I just want to echo a little bit. People often think that rapid response nursing is just a sprint from one code blue to the next. But it's actually a lot more resourcing and support and precepting and education. It's way more of that than code blues. I probably see 5 to 10 code blues a month personally. I mean, there's more that happen in my hospital, but just for my shifts, it's not just code blue after code blue. It's a lot of emergencies and a lot of education. So I'm glad that your heart was drawn towards the support role, not just I want to sling up an epinephrine and do CPR, because it's not actually that much of that. So
exactly.
How would you say that the pace and the workflow of rapid response nursing is different to ER nursing?
I would say, similar to the ER, you don't know exactly what your day is going to look like. Certainly, it's going to get busy 2-3 o'clock. You're going to be like, oh man, we got a big waiting room and all that now. But rapid response is totally different. There's some days where I do really nothing except for round in the hospital for 12 hours. Some days where I just put in IVs all night. And then some days where I'm just going from critical patient to critical patient. So that part is different. And, when you get that alert on your phone, it's kind of always related to the EMS radio coming through. You don't know what you're going to get, what this patient's going to look like. But then at the same time, you have a second to prepare yourself for that patient too. Usually when I get a call, I'll look onto the computer and see what this patient's here for and things like that. And you kind of have an idea of what's going on a little bit with the patient versus in the ER when this person just shows up in your room or from the ambulance bay. You don't know anything about this patient and it's, totally undifferentiated. And I think that's a little bit different.
Yeah. So just to clarify, because it sounds like it's different than my facility, I'll just be like hanging out, eating some snack or going to the bathroom. And all of a sudden I get rapid response room 302 and I know nothing. And I just start sprinting across the hospital, not knowing what I'm walking into. It could be something simple like a seizure or patient has chest pain, or it could be like, oh my gosh, they're gray.
Oh, yeah.
I never know what I'm walking into. So are you referring to like nurse consults where the nurse calls you and says, will you come take a look? And then you look in the chart first? Because I definitely don't look in the chart before I run across the hospital.
We have like an alerting system. It'll tell you they have to essentially pick a reason why they're calling rapid response.
Okay.
So a lot of what I do is get second opinions. So I'll try to look at them beforehand if I'm at my desk and I'm at my computer.
Those make sense, right? You would look at your computer. Okay, gotcha.
Yeah. If it's a stroke alert code, heart rate rhythm changes, things like that are, more acute, then I'm just going right to the patient. But
right.
a lot of what we do is those second opinions that I'll kind of read up a little bit before if I have a chance to know what I'm walking into.
I gotcha. Yeah, I do the same thing. I will like, the nurse texted me and says, will you come liaison my patient? They're acting different. So I'm like, let me just take a quick peek-see at the labs before I head that way.
Yeah.
We actually can pull up all the patient's lab and diagnostic information from our phones. Like we have like a hospital issued phone system. And so as I'm like walking there, I'm like scrolling through the lab, scrolling through the imaging just to kind of get a feel before I walk in the door. I'm with you there. What do you feel like was the biggest challenge that you faced transitioning from the role of ER nurse to the role of rapid response nurse?
I think you're so used to your team down in the ER handling those critical patients and everybody being well-versed in those next steps. And we have excellent floor nurses. I'm really lucky for that. But, they're not exposed to as many critical situations and codes and whatnot as you are in the ICU or ER. I think that's the biggest thing is kind of just being a bigger delegate for tasks and things like that and really being clear in your communication. Just because, they might not know sometimes the next steps and what to take and, what to do in that exact moment. So I think that's the biggest difference. That, and then, as we mentioned before, just a lot of the education and being a resource and understanding your skill set and capabilities versus the others in the hospital and kind of just being flexible and mindful towards that.
Right, for sure. That's definitely something that I faced as well. I'm so used to like everyone in the room being ACLS certified, and we just did this 5 minutes ago, and everyone's like ready to jump in and do whatever, to showing up to a code, say on the floor or like in the cafeteria, and the people that you're working alongside, this is not their favorite thing to do. Like they're not super stoked about cardiac arrest or crashing patients. This is a bad day for them. And maybe they haven't done this or even exposed to this ever. Either it's been a long time or it's been never. And so this feels very uncomfortable. So just being aware whenever you're delegating who in the room is able to take on the task that you're giving. And something this is like simple in my mind, even just putting together the Bristojet like epinephrine. To me, that's just like second nature. Pop, screw together, go. But if you've never seen one of those before in your life, of course you're going to be like, what do I do? What is this thing?
Oh, yeah.
So just remembering like, okay, not everyone has it's not that they are any less smart. It's just they haven't been exposed to it. I didn't know how to use a Bristojet when I had never seen one either. And so just kind of learning how ACLS kind of goes and the rhythm and yes, definitely being aware of that as I show up to the room and reading the room, right? Not everyone's stoked about this cardiac arrest. There's going to be always some nurse that's like hyperventilating or super anxious or like kind of shutting down because this is very overwhelming. And so being able to lead the team and also support the patient and support the team simultaneously is definitely a new challenge that ER nurses really haven't faced before, and they get to face that in the world of rapid response.
Yeah, I think that's a good point because in the ER, you don't want to wish bad on anybody, but you want to be there in the face and at the face of chaos and kind of be in the mix and everything like that. And you kind of forget sometimes people, freaks people out and they don't want to be in that, which I get.
And what cracks me up is nurses will be like, oh my gosh, you've had a rough day. You've had what has it been, 12 or 13 rapid responses? And in my mind, I'm like, it's been a great day. I had so many fun emergencies I got to manage. But for them, it's like, oh my gosh, all those emergencies, that must be so stressful. And I'm like, no, yeah, this is a blast for me. I love being able to show up and support people in crisis. This is not a bad day for me at all.
Yep.
I mean, I feel bad for the patients, but I got to help. So to me, that's a great day.
Oh, yeah.
So yeah. We're all wired different, right? We need all types of nursing for sure.
Oh, we do.
Were there any skills or mindset shifts that you had to develop or kind of hone in on? Maybe that you didn't use as much as the ER nurse that you've had to really, use well in the role of rapid response?
Yeah, I think the biggest thing is just being mindful kind of their inpatient course. In the ER, we're so quick to just throw 3 liters of fluids at someone or, just draw a rainbow of labs.
Fix the blood pressure, check.
Yeah, just make them look good on paper until they get to the unit, right? So I think just being mindful of their course and being like, oh man, you know what, they've already had X amount of fluids, clearly not responsive for a reason. And, us ER nurse to get the rap for putting the 2 IVs in the AC and things like that. But I try to be more mindful of that being on the rapid now because I'm like, well, they got to sleep here overnight. And
right.
It's going to go bad. So just trying to make the inpatient course smoother rather than just focusing on stabilization, I think has been the biggest difference for me for sure.
And again, as an ER nurse, you're not really forced to face that so much, the consequences of an AC line. You deal with it for a couple hours and the patient's out of your area.
Yeah, exactly.
But when you have a patient that needs that IV to work for 3 days, and it's in the bed of the arm, the pump is beeping, or, you give some fluids to fix the blood pressure, you're like, sweet, fix them, on to med-surg. And the med-surg is like, oh my gosh, now they're fluid overloaded and we're working to diurese them. And they got this darn AC IV that keeps beeping.
Yeah,
it's definitely a different perspective. Okay, so with all of that in mind, I wanted you to talk about the case that you shared with me of the patient with the subdural hematoma. Can you just walk us through, what were you told? You showed up. What did they tell you about the patient? What assessment findings did you discover as you were arriving to this rapid response?
I was called for, I believe, altered mental status or second opinion due to altered mental status. I was familiar with this patient. I had seen her a week prior for a really similar call. She was a elderly female admitting was AFib and some altered mental and whatnot. So they, like I said, the presentation was almost exactly like they had called me for the week before. This was around 2 or 3 in the morning. They said she seemed lethargic. She was nodding off during conversation, and they said she was having these kind of almost shaking episodes, but they didn't describe it as seizure-like activity. This particular patient, she had multiple causes for, altered mental status. She was dealing with frequent episodes of just transient hypoglycemia, hypoxia, UTIs, things like that. So kind of a broadish differential. And like I said, it was a very similar presentation to when I'd seen her last week. And actually, the rapid nurse who works different nights than me, I'd seen her as well. They did a whole code stroke on her, which was pretty unrevealing. That was just about 5 days before this call. So I got down there. She somewhat alert, not really, definitely frequently nodding off, definitely lethargic. She has just chronic AFib, unfortunately, just not a candidate for anything. So she's usually 100 to 120 on the monitor, but her vitals looked okay. She was afebrile. She didn't seem shocky or anything like that. Her blood pressure was okay. She was dealing with some hypothermia as well, too, where she was requiring the bear hugger almost every other night. So she was I think 95 or 96 degrees when I got down there. I had them check a sugar beforehand, which was within normal limits. And the sugar's been okay all night. So we kind of ruled that out. And she still seemed pretty lethargic. So we did a ABG, just ruled any hypercapnic respiratory failure, hypoxia, anything like that. That was pretty unrevealing. And then really the only neurosymptoms she was having that were new to me was just that lethargy and kind of just dozing off. Her pupils were equal and everything like that.
Which is the vaguest symptom ever, right? For an elderly patient who's sleepy.
Yeah, exactly.
Who's been in the hospital for a bit. I bet she is sleepy. It would be very tempting just to be like, then let her sleep, y'all.
Yes.
Right.
Yeah.
So what was it about her that made you not just be like, okay, we're fine here. Let grandma go back to bed. What was it about that was different?
I think a couple of things. So last time I had mentioned they called me for a very similar presentation. She had perked up that last time, maybe within 10, 15 minutes or so, and was talking to me, answering questions and whatnot. This time just seemed more delayed. And then, interestingly enough, her platelets had been decreasing the last day or two. I think they were down to 50 that day. They had restarted some oral anticoagulation as well that day too, and they were kind of just being mindful of her mental status due to that. So I was like, you know what, I feel like we should probably just advocate for her a little bit, reach out, because, this ABG is unrevealing, the lactic acid is unrevealing, vital signs are on paper okay. We got to be missing something here. So we reached out. The provider was a little bit hesitant to do a scan because she had just had a recent MRI, stroke workup, everything like that, which was negative. And then we took her down for a CT, and about an hour later, it revealed a subdural hematoma.
There you have it. Thank God you scanned her noggin. Wow. Okay. Yeah. So as far as managing this patient, it sounds like you did all the right workup, right? We're going to rule out hypoglycemia. Blood sugar's fine. Check. We're going to rule out shock. Like lactate's fine. Okay, that's good. Blood pressure's good. Okay. The hypothermia is kind of a weird little side thing I would want to go on a tangent on, trying to figure that out, but we'll address that later. You did an ABG, make sure she's not hypercapnic. Check. So yeah, basically all you're left with is, why is she not waking up? I know her baseline. I know she will wake up and talk to us.
Exactly.
Must be neuro, right? What else could it possibly be? I guess there's delirium as a possibility, but you can't ever diagnose delirium with a diagnostic test. You just have to rule out all the other bad stuff to get to that diagnosis.
It's, diagnosis by exclusion.
Exactly,
right?
Exactly. So any challenges you faced in managing this patient that you had to overcome, or barriers you had to kind of work through? You mentioned the doctor wasn't super stoked about doing the scan. How did you convince him it was worth it? Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that, because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now wherever you get your podcast. Give it a listen. Now, back to the episode.
Yeah, because it was, how people can get sometimes during night shift when it's 3, 4 in the morning, we'll just pass it on. I was I don't know. I think, I've seen her. I think we should probably, nothing else is showing up. I think just with the gray area, neuro can often be, it can always be a gray area. I think we should probably just scan her. And he was all right, let's just do it. And then nonetheless, we had our answer with that. And then her nurse, I have a good relationship with too. And he was just she seemed off the last night or two. He had her for multiple days too. So that was kind of alarming to me, just listening to him being if something just isn't right. So I think with his intuition, my intuition, you might as well. You're not going to harm her usually with a CT head without contrast.
Right.
You might as well do it. So
I agree. So it was a combination of I've ruled out all the things, plus my gut says something's weird, and the primary nurse who knows this patient even better also says something's off here.
Yep.
Let's the power of joint intuition. Let's advocate for this patient. I love it.
Right. Yeah.
Gotcha. Do you have any other examples where that intuition piece came into play to help you push you over the edge towards a certain intervention or a certain diagnostic? Because sometimes the numbers look fine, the vital signs are fine, but the gut says something's off.
Yeah. I would say fairly recently, back when I was in the ER a couple months ago, we had a youngerish patient. She had a car accident. She was, I think, of a 40-year-old female thereabouts. She'd had a car accident a day or two before. Was having a lot of kind of non-specific chest pain, jaw pain, things like that. She'd actually been to an urgent care earlier in that day. And this was, I think, around, midnight, 1 o'clock in the morning. Been to an urgent care earlier in that day. I was just basically diagnosed with a musculoskeletal chest injury. I believe they actually did an EKG there, which is unrevealing. And then just her story, I was I think we should probably just, kind of do an EKG. I was working triage at the ER at this time. And she ended up having a STEMI, which was just a very weird presentation, especially with kind of the normal findings earlier in the day.
Right.
She ended up having a STEMI. She did well, but I think that was just one of those things where it looks okay on paper, but something just not adding up, not really passing your eye test. And then that sixth sense of that we develop, as nurses, especially in triage and what just comes into play. And you're not going to do any harm, and you might as well get it just to get it.
Right. Check that off the list of things to worry about, right? But nope, we're going to worry. Looks like ST elevation. I had a very similar case where a patient came in, young guy, had neck surgery, still had a C collar on from his neck surgery. And he came in complaining of neck pain. Okay. And so I think the diagnostic bias is okay, neck surgery, plus now a week later, neck pain. He's clearly wearing the C collar. It just seems very neck related.
Oh, yeah, yeah.
So if you know ESI, they made him an ESI level 4, which is a lower acuity patient in the ER. He waited in the waiting room for hours with his neck pain because vital signs are stable. He's young, otherwise healthy, right? So finally a room opened up in my area and I brought him back to the room. As a new nurse, and my sixth sense was still developing, so I knew something was off with him more than neck pain, but I had no idea. I couldn't even make a guess. I was just maybe it's his heart. I've heard that you can have, jaw pain with STEMIs. And I brought him back to my room. I put him on the heart monitor and he's oh, I don't have any heart problems at all. As I'm putting the leads on, I was I know we do this to everyone. Welcome to the ER. Everyone gets a heart monitor. And as I'm putting the leads on, I look up at the monitor and I see tombstones. And I was and I try to control my face. He goes, "Are you okay?" I was "I am. Yep. I'm going to go grab the doctor. I'll be right back." I was brand new. I was am I seeing what I think I'm seeing? What is this? Sure enough, big old STEMI. His only symptom was neck pain. And inconveniently, it was after a neck surgery. And so everyone just wrote it off, understandably so. But my gut, I didn't know what it was, but I was something is more, it's more than neck pain. He just looks not okay. Not okay. He was a little glistening, a little tiny bit diaphoretic, which could be from pain, neck pain, or could be from a STEMI. Anyways, yes, trust that intuition.
Always. Yeah, always.
Would you say that working rapid response has changed your perspective at all as far as patient deterioration or early warning signs? Because it is just a different environment. In the ER, we expect everyone's worst case scenario. But outside of the ER, we expect they're supposed to be getting better, right? Where I was oh yeah, they should be getting better. So how has it changed for you since you transitioned to this role in rapid response?
Yeah, I think that's exactly like you said, they should be getting better. I think you forget sometimes things can happen in the hospital too. They can get more sick. I think that's the biggest eye-opening thing. And then obviously paying attention to the deterioration scores and everything like that. I mean, frankly, we know it's hard to heal in the hospital sometimes, especially for these really sick patients. And catching those things early is just so vital. And those Muse scores, and it really, it can be nothing sometimes and just trigger for nothing. But a lot of the times it really is pretty spot on. It's usually worth investigating these patients that you're getting alerts about. With I think understanding that, people can get worse under our care. And sometimes we are missing something and have to dig a little bit further because conditions can change from whatever they initially presented with.
Yeah, for sure. And I think too, we often forget that patients are going to have 2 diagnoses happening at the same time. They come into the ER oh yeah, we discovered pancreatitis. All right, let's treat that. We're so focused on the pancreatitis. And then the patient, I don't know, develops a brain bleed or something totally unrelated could still happen to this patient. One of my coworkers, she was caring for a patient that came in for sepsis, had a known decubitus ulcer. So we're all sepsis. They became acutely hypotensive. And they're oh, sepsis, right? SIRS, they're SIRSing. Oh no, it was an aortic aneurysm. So we weren't expecting that. They didn't come to the hospital for that. It just happened to happen under our care. And it happened to be disguised as hypotension that we thought was from the obvious source of sepsis. Oh no, it was much more than that. So yes, keeping in mind that 2 diagnoses can happen at the same time, so not to miss them.
Oh yeah, absolutely.
I love these cases. I think they're great examples of the role of the rapid response nurse. Again, it's not always running a code blue. Sometimes it's just a second opinion. And that intuition kind of comes up and you have to help advocate with the nurse. Personally, I love this role. Are there any other aspects about the rapid response role that's different from, say, the ER role that you want my listeners to know about? Any things that surprised you or things that you feel the world doesn't know about rapid response nursing that they should know?
I hope they know that the vast majority of us don't pass judgment.
Yes.
I have nurses ask me sometimes, they're "Oh, do you think I should have called? My charge nurse says I shouldn't have called." I'm if there's any doubt in your mind, you are the nurse, you call if you need to.
That's right.
I'm I tell them all the time, I'm here for whatever you need. It's not an inconvenience to call a rapid. It's not an inconvenience to reach out for help. Sometimes we don't know things either. I think that's the biggest thing is sometimes,
Yes.
we have to ask questions. We certainly, we are not the providers, and we need second opinions on our behalf sometimes too. And
For sure.
try to just give everybody grace, but we don't like to go into rooms and pass judgment and be harsh on people, because I've seen that before, and that's not fair to anybody.
Is there anything that maybe a bedside nurse could do whenever you show up that would help you? You show up and you're kind of gathering data, and the nurses give you, hopefully a quick summary of what led up to this event. Is there anything that you're like, oh, I wish they would do this, or like, you don't have to do this? Any experience like that you wanted to share with people?
Yeah, I think the biggest thing is I would say for the vast majority, they're okay. They're usually good about getting the baseline vitals, get a glucose, things like that, if applicable. I would say just being in the room with the patient sometimes.
Don't leave me, please. I know nothing about this patient. Come back.
Sometimes I'll show up and there's just nobody in the room. I'm like, well, I need some background. I would say just a good brief synopsis. I don't mind asking, what are they there for, but just, have a brief synopsis, maybe some important labs, what medications they got. That's always a big thing, like medication changes. Did they get narcotics, things like that? Anything that could really alter their course of care that you know of. Obviously, it's hard on the floor. I've been there if you have 4, 5, 6 patients to keep everybody straight, and I totally get that. But I think that's the biggest thing, is just try to be present as you can in that room and with that patient. Sometimes it's hard when you have their needy patients to really be in that room with the rapid team and be fully present. So I think that's really the biggest thing. We can always, I can always talk to the charge nurse and have them take over the patients or have someone look out for the patients. But, if you're calling the rapid, then I think in my eyes, that patient needs your direct attention right now. So really just having, good synopsis of why they're here, vitals, critical labs, things like that is the biggest thing for me.
Yeah, I agree. I think a lot of nurses are so used to giving bedside report, to the oncoming shift. And so that's what they're used to do. That's what they know well. So they try to give me that. Patient was admitted on, 9/7 for appendicitis. They have a medical history of, 37 acronyms. Plus, they recently had, I don't actually need all of that. I just want to know, they came in for this, and this is what's been going on lately. Or, here's my most recent set of vital signs. Or, this is the med I just gave. Or, my gut says it's this. Or, I have no idea what's going on. That's fine, too. But I definitely don't need every single date of every single surgery they ever had for this particular SBAR about the patient. So, yes, for sure.
Right. Yeah, I like to know what exactly changed. Sometimes you're like, oh, I've been thinking about calling over the last couple hours. I want to know what exactly prompted you to call at the moment. It's like asking patients in triage, what
did you come in for today?
I know I know your belly's been hurting for a week, but what made you come in today? What changed things?
Right. That's good.
But I think that really narrows things down.
Is there any advice that you would give to an ER nurse who's thinking about transitioning to rapid response nursing?
I would say try it out. I think it's been a welcome change. I did a shadow shift before I had accepted the role just to make sure I liked it. I think that's important to do, but I would say just try it out. If you have any inkling or any interest in doing it, I think it's a great break too, and a great kind of way to be on the inpatient side of things a little bit and kind of, like I said, kind of see the patients going from the ER to the floor to the ICU, whatever it may be, kind of just seeing the care followed through. And I think trust yourself too. Trusting yourself in those situations and challenging yourself too, because it's a lot more mentally draining, I think, than physically draining.
Yeah,
which is good. It's always mentally stimulating, I think.
Are there any personality types or characteristics you think would do well in rapid response, and maybe those that would not do well in the role?
I think those who like to teach and to be a resource, if you like the precepting in the ER, or if you have some charge experience and things like that. If you're just the person who's just wants to take your section before and not be bothered, which is totally fine too, because they're great ER nurses. I would say probably don't do it.
That's good.
If you like to be like that float nurse, especially I used to do float nurse a lot in the ER and just help with anybody's needs. And that was my favorite role. And I think if I like to do that and kind of just be in a variety of different areas, then it would be great for you, because I can be, I've gotten to OR codes, cath lab, just you name it. I'm kind of all over the hospital now, and I really like to have that role.
Awesome. Yep, I'm with you. I loved being assigned float nurse. That was my favorite assignment.
Yeah.
It's all the fun and a little less documentation. Bring it on. I love being the float nurse.
That's the best.
But I love working with other people and extrovert. So I like the opportunity to collaborate and support other people. I actually don't want to just work by myself in a cubicle and just To me, that's just too tasky. I like the human connection of, caring for the sick with my besties. So yeah, I'm with you on that.
Yeah, exactly.
Well, I feel like this is a good glimpse into rapid response nursing and maybe some of the differences from ER nursing. So thank you so much for sharing all this, Aidan. Any other closing thoughts or things that you would want to make sure the world knows?
I would say, just going on the basis and the message of the episode, just trusting that sixth sense. It takes time to develop, but if you just have that gut feeling, I know it sounds super cliche, but even if you're getting pushback from another nurse, from a provider, don't be afraid to make that extra call, get that second set of eyes on a patient. Because, really, you're not doing any harm to a patient by asking for help. And by getting more resources involved, you're only advocating for that patient and hopefully going for more positive outcomes and getting ahead of things and being proactive in their care versus reactive.
Absolutely. Amen. I would much rather be wrong for advocating, like, oh, they actually didn't have anything wrong with them, than be wrong for not advocating and they're like, brewing sepsis or a brain bleed or something that we're totally missing because I was afraid to speak up. I would much rather look stupid, and I don't think you look stupid, but the concern of looking stupid is there. Whatever. Think what you want. I'm going to advocate if I feel like I should advocate rather than stay quiet for fear of someone thinking that I'm, overkilled. So I'm with you 100%.
Yeah, absolutely. I think, there's no need for that stigma to be worried about people thinking you're wrong. I think if you believe you're doing right by the patient, then just go ahead and do it.
And that's what we're called to do, right? Do right by the patient.
Yep.
All right. That's a great note to close on. Aidan, thank you so much for your time and for sharing this story. I'm so glad you joined the world of rapid response nursing. I can see you would just thrive in the role for sure. And that's it. Thank you so much. Have a great rest of your day.
All right. It's been a pleasure. Thanks for having me on.
Thanks, Aidan. Bye. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.